Welcome to the Never Covered Services Getting Back to the Basics webinar. Whether you bill indicating Medicare doesn't cover a service or you allow the system to process for this denial, data does indicate it is one of our top denials. This is why we're going to include this information in a webinar today. I'm Tom Ryan with Provider Outreach and Education. I'll be your presenter. Today, I'm joined by Karen from my team, who will be helping me with the chat. She gets to ask the questions that are put in there to me later on, and she will also be giving you some additional resource items that you might want to be aware of. Remember that if you would like the presentation, you can download it today from the live events page, but you could also download it in the future from the Encore presentation page. I want to remind you that the last slide, I'm not going to cover it during today's presentation, but it is just simply a disclaimer. So if you're interested in that, take a look at those last few slides. What is our goal today? Our goal is to reduce the denials and billing of the not covered services. Now, I do know that sometimes there's a reason to do it, a reason to bill them, a reason that you need that denial, and that's okay. However, from the pre-submitted questions, there's quite a few people who don't really know whether they should be billing those or whether they need to. We'll go through that in just a little bit. There is a couple of resources that you definitely need to be aware of, and these resources are its own separate section. So I'll mention them in the first part. The middle part will be actual resources, website resources you can use. The last part is just, hey, what are you asking us? We will begin with pre-submitted questions that were entered during the registration process, followed up by chat questions. So lots of stuff to go over, so I do want to get going. Again, though, do want to encourage you at any point in time, if you have a question or a comment, please put that in the chat. We'll get to those and we will answer those eventually. All right. Let me say that the first thing that I did have to look at was who's new, who's coming on, what are they asking me? So we did get some really basic pieces of information being asked for. And they said, you know, what is a never covered service? Well, to do the best I can for these people, in other words, to not lose those people who are new to Medicare, which we actually have people that are new on here, that we're looking for clarification on what is never covered or non-covered. I wanted to start back with some basic explanations, stepping all the way back. So for some of you, this will be a review, but please keep in mind there are people on who are brand new to Medicare, just getting started. I know that because they told me that. In that pre-submitted question area. Also, again, we wanted clarification or starting at the beginning, what do I have to know? So let's go ahead and start with a definition. What is an excluded service? What is a never covered or not covered service? For the purposes of this webinar and for Medicare, an excluded or never covered service, not covered service, is something that is excluded from coverage under the Medicare program by statutes. The law says, no, you can't cover that. These services are not payable under Medicare. They are not payable even when the provider indicates that they are medically necessary. Excluded means no coverage. So if you think about it from a commercial-based insurance, it's when they say, hey, your policy simply doesn't cover this, so you have to pay for this. It's the same thing for Medicare. Who is the you paying for it? In this case, it's the person that's eligible for Medicare. So these services are never something Medicare will pay for. They are billable to the patient, and they are the patient's responsibility to pay for these items and services. A couple of people did ask for some examples. I think this is a great way to get started. So let's talk about just a few of these examples. I'm not going to go through the whole slide. First, routine services and appliances. If it is not something that is medically necessary, this is why it's defined as routine. The one item that people look at and say, well, isn't this routine? Is preventive care? And the answer is no, it's not considered a routine. It's a prevention service. Prevention services are covered under a different section in the Social Security Act than medical necessity services, but they're still covered. So don't confuse a routine service, such as a yearly physical, with a preventive service, such as the annual wellness visit or initial preventive physical exam. Two very different things. Also, don't confuse cosmetic surgery with reconstructive or otherwise covered surgery. What is a reconstructive surgery? And this is a question that was asked. I think they looked at the slide and saw that we had cosmetic listed underneath there. It was a recently submitted question. If you think of plastic surgery, which is done for a couple of different reasons, think of a breast cancer survivor. They're having reconstructive surgery, not cosmetic surgery. Yes, it is still plastic surgery. Yes, it is something that they need done in order for mental health. I myself have had plastic surgery. I had a nose reconstruction because when my nose was broken, I couldn't breathe through it anymore. So they did this surgery to allow me to even be able to use my nose. That's not something that is cosmetic in nature. Didn't change the look of it. What it did was allow me to use the functionality of my nose. So don't get confused with cosmetic surgery versus like plastic surgery. It's not always the same thing. One of the ones that someone did ask about is dental services, and they said, well, dental services can be covered. And the answer to that is only to the extent that they affect an otherwise covered surgery or other service. So in other words, routine cleaning, not covered, right? It's your basic dental services. Now, if you say they had to pull all of the teeth because this person has an infection, in order to treat that infection, the teeth can't be there, we need to do a jawline surgery, something like that, that's where dental services can be covered. So you're noticing some of those different exceptions that go on. But this is just, again, starts with your basics. Okay. One thing I do want to say is under excludes investigational devices, CMS can allow coverage for certain investigational devices. This is not something that is an absolute no. In most cases, though, if it's not approved by the Food and Drug Administration as a drug, or if it's not, whatever the service doesn't prove to be medically covered, then it's still under investigation. Now, again, if it's an investigational purpose, that's fine. If it's an off-label purpose, some of those can be covered. So I just wanted to give you a few examples and then clarify, of course, because with Medicare, we all know that it's clear as mud, right? No, just kidding, everybody. It can be very hard to keep through that understanding, okay? With these examples, one of the questions that was asked is, what are clinics to do when a service is never covered, such as some of the examples given? My first recommendation is begin with, is it excluded under the law? So that's a different area, or is it a medically necessary, not medically necessary service? And we'll talk more about that in just a few moments. Because not medically necessary services means that it's not for someone today based on their diagnosis code. It's different than an excluded service, even though when you read through the exclusions list, it says medically necessary services are excluded. We'll get a little bit more into those. Which led me to add some additional slides. One, if it is not covered because there's no obligation to pay, then there is no Medicare coverage for it. Let's give an example. I pay taxes for ambulance coverage. Because my taxes pay for that coverage, I'm not obligated to pay an individual. It's part of my property tax, my tax that I'm paying. You have no obligation to pay for that service. If a product is covered under a warranty, so you have no obligation to pay any money because the warranty is replacing it, again, you have no obligation to pay. If something is covered by another federal payer, this is the second bullet. This is where the Veterans Administration comes in, and it simply says if VA pays, Medicare will not. If the VA does not pay, then Medicare can consider it. So Veterans Administration coverage. Quality check or review, basically you're not doing it for a medical reason, you're doing it to make sure you did it correctly in the first place. That's not something Medicare will pay for. This is not for a patient requested second opinion. Those can be payable. It's just when your organization has a certain something in place that is a quality check. Okay. We already talked about items under warranty. Those are also no obligations to pay. Cosmetic surgery, purely for cosmetic purposes. And then comfort items, such as a fan while you're inpatient in a hospital. Those are just things that, don't need to be paid. So those are types of not covered services. Then we get into the one, and I added this slide in because there was a few questions that came in about medical necessity. Even though medical necessity means it doesn't fall under the category of not covered, medical necessity means it may be covered. You have to determine the diagnosis. And is it something that should be covered based on diagnosis for that patient today? Is it standard? Is it set for? Is there a policy, whether national or local, that excludes coverage? This is different. Okay, so when we're looking at not medically necessary services, what we're looking at is the diagnosis and a treatment needed for the patient's condition? If it's needed, in other words, medically needed, then it would be covered. This is part of the definition in Section 1862 A1A of the Social Security Act. Different than exclusion sections. One of the common sections, I'll show it to you a little bit later. It'll have a slide for it, but you'll see Section 1861. That section just simply says this is not covered, or this is what makes it covered. That's not just medical necessity in general. So we want to make sure that this is emphasized in that manner. Okay. Some of the interesting questions that I got is, well, what happens if it could have been done somewhere else at a lower cost? Well, that means we should be utilizing that service. So for instance, is it medically necessary to remain in the hospital when you could be treated at a skilled nursing facility and be providing those care that they can cover, which is actually cheaper than a hospital, right? What other types of things could happen? Well, would it be cheaper if the professional, whether it's a PA, a physician's assistant, or a doctor, came to the hospital or the skilled nursing facility to perform the service versus transporting that patient to them? So we want to look at all those types of things, and that's why there's different items. Medicare also sets certain limits for lengths of stay, and this is always on inpatient. So if it exceeds the Medicare coverage criteria or the Medicare requirement, then that will automatically make it not payable. It's not that it's not medically necessary, it just falls into this category only because it could have been billed had it been within those categories. There's also some discussion on evaluation and management services and its incorrect billing of them. So when you go to code them, do they meet all the criteria? This is one that we've seen, up coding, but we've also seen down coding. So it's not medically necessary at the level coded, not the level, not that it's not a medically necessary service. I apologize for that. It's just a coding thing. It's not medically necessary at the level coded, whether up or down. One of the other ones is outpatient rehabilitative services, and that's where it says excessive therapy. Many of you have seen the KX modifier, which needs to be coded independent to indicate, yep, we should continue this above those therapy thresholds. Okay. Also, diagnostic procedures. Sometimes patients come up with things they want to have diagnosed or looked at, but you're really like, why would we need to do that procedure for that? That's just an example, but if it's not medically necessary, there's no reason to do it. Also, with diagnostic procedures and other types of procedures, we do have the patient who passes away. And so technically your reading is done after the patient passed away. It's not medically necessary to read that service. Why would you need to read a service? For a patient who's already passed away, what are you doing with those results? Okay, so Medicare doesn't pay for that. So those are just some different things to think about. And then unrelated screening tests, exams, and therapies where the patient has no symptoms or diagnosis. Again, why are you doing it? What's the purpose of it? Oops, I was asked if there are some exceptions to medical necessity, and the answer is yes. So for instance, preventive care has its own section in the Social Security Act that says preventive care is covered. Well, is preventive care medically necessary? Not my argument today, right? Everyone catch that? It's not my argument today. Whether you believe preventive care is medically necessary to avoid future situations, that's up to you. Here's what Medicare says. Preventive care is to avoid costs in the future, therefore it's covered. That's what the law says. It's not that preventive care is medically necessary. It's not that a patient has been diagnosed with a certain condition. It's that they may have the potential for it, or that at this age, this should be done. That's what preventive care in general is. Okay. The other three listed here are just transition care, chronic care management, and advanced care planning. And again, CMS does indicate that these are covered items and services, though you may argue they're not medically necessary. But what they're doing is they're trying to prevent that future care, that future expensive or items that could eventually be avoided by utilizing these services. So, um, we were asked quite a bit about documentation. I do have a few, and they were like, do you have documentation standards for a not covered service? First, no, because documentation has to support the medical necessity. Therefore, the only items we have about not medically necessary services are the basics of documentation, and that's the patient's information, the provider information, the service date, and the location. Now, with that said, if you want to add a little note, highlight something that would be covered, such as preventive care, you may need to document each component within the preventive care to make sure that you're doing everything that CMS requires, but it's not about medical necessity documentation. Then it's about making sure it meets the criteria for billing that care. Okay, so it's a little bit different there. I'm not really sure what else you were looking for with documentation. So I'm going to leave that one alone and go ahead and go on. But if you do have more, definitely put that in chat. Help me understand what you're looking for. Okay. Not covered services are denied without appeal rights for the provider. The question that we got relating to this particular one is that this provider got a letter stating that there was an appeal done, but they did not file an appeal. So how is there an appeal done? Well, you are correct. When you looked at your remit notice, you did not have appeal rights. You did bill it correctly, probably. I can't guarantee that because I don't have the documentation. Here's the thing. If the provider files the appeal, it's automatically dismissed. So how did you get a letter that this was a valid appeal? What if the patient files an appeal? Medicare will consider that appeal. As a matter of fact, we will take the redetermination, which is the level 1. We typically are going to send you a letter asking for documentation. What we're looking for within that documentation is, did you bill it with the appropriate modifier, or did you bill it for a non-covered item, as you should have, based on the Social Security Act, based on whatever you're making that non-covered for. So hopefully that answers where the letter actually came from. Yes, it came from the Medicare administrative contractor. Yes, it was an appeal. And yes, we did ask for documentation, but it wasn't you that sent it. It wasn't the provider, it was the patient, which means we have to review it based on the patient's request. Okay. I was asked about not covered services for specific provider types. This is very common for some providers. Look, you don't meet the Medicare criteria. You're a licensed social worker, but you're not at the correct level. You don't have the clinical experience. You're not covered for Medicare. It's that simple. You're just not covered for Medicare. You are a nurse, a registered nurse. While your services may be covered during a skilled nursing facility stay by the skilled nursing facility payment, because that's what they're there for, your services individually billed for professional services would not be covered. Now keep in mind that doesn't talk about incident to billing, because we're going to leave that whole section alone. But really, when we look at this, yes, a provider can be not covered. In this case, when a provider is not covered, this means they do not meet the Medicare criteria for coverage. We'll give you where that is located at in the resource section next. A couple of things to keep in mind. If you try to bill us for this provider, we will not be able to process your claim. Okay, we can't do it. Even if a secondary insurance wants that denial, there's nothing we can do with it. We can't process that claim. That provider is not in our enrollment system as an active provider. Even if the patient says, bill this, we have to have this billed to Medicare, which patients can do. We still can't process the claim. the provider doesn't meet the Medicare coverage criteria, so it's not covered for Medicare purposes. One of the questions was, how do I get these covered? I don't have any answer to that. Medicare excludes that provider from coverage, so you won't get them covered by Medicare. If you're talking about how do you get it into the system to get it paid, or I'm sorry, to get it denied for a secondary insurance to Medicare, again, there is no way to do that. The Medicare system does not allow for these types of services. So I don't have any way of saying, hey, do this, it's going to automatically do this. It's going to, no, because it's not even going to pass or validity at it. You don't have a valid provider number. You can put the MPI on there, but it doesn't translate to a valid provider transaction access number, which is what we need to process the claim in the system. So hopefully that all makes sense. Again, lots of questions already answered, but I do have a lot more to go through. So the next is just consider the following for billing. I was asked for billing advice. Do I bill Medicare first for never covered services? Yes. If there is no primary insurance. If there's a primary insurance, then you bill the primary, then Medicare. So make sure you do that. When you're billing Medicare, should you add a modifier? First, this one bills both on a UB or 837I and a 1500 or 837P. So let me put it this way. The UB04, if the entire claim is for a not covered, then you can just use condition code 21, be done with it. If on the other hand, there are some covered services or you're billing on a 1500 or 837P, then you do need to use a modifier, and it's GY, indicating it's non-covered, and you did not give an ABN, which you are not required to, but you didn't give one, or modifier GX, which indicates it's non-covered, but you did give them an informational ABN. Now, an ABN is an advance beneficiary notice of non-coverage. Simply a form indicating, hey, Medicare never covers this. It's excluded from coverage. The law says no, however you want to say it. We'll talk more about that. So when we really look at this, and you ask me the question of, do you need to bill it? I don't really have a direct or a good answer, okay? If you say, yes, the patient told me to bill it, yes, you need to bill it. If a primary insurance says, I need that denial, then yes, you need to bill it, with the exception of the providers, because we can't get those ones through. Do you need to include the GYGX or condition code 21? Nope. The service is never covered and will be a technical rejection, which means it's not appealable and it's not covered. It's just not part of the Medicare program. You will not get appeal rights with it. However, that technical rejection does allow the patient appeal rights. So I'm not sure where to go exactly with that question. The other question that came up with that is never covered means no GY is needed. That is technically correct for our system. There is no modifier or anything that is needed. Now, I did just tell you, hey, wait a minute. We recommend using GYGX or condition code 21. Yes, we do. We recommend that, absolutely. I'm going to tell you on a UB04 and 837I, use condition code 21 if the entire claim meets the non-coverage. I will always tell you to use GY or GX, and the reason that I do this is because the GY and GX cause it to process faster. It comes through base validity edits, which is, hey, is this a valid patient? Is this a valid provider? Those types of base edits. Is it a correct data service type thing? And then it kicks it out from there. It doesn't have to go through all of the medical necessity edits. It doesn't have to go through the processing timeframes. None of that applies, including the payment floor. So my recommendation, put it on there, tell us, and just let the system do its thing. We did have quite a few of you ask me about the ABN and whether or not it's a required item. So I thought, well, I'm just going to build a slide with this one. So first, you're providing this as a courtesy. Some people call it the curiosity of Medicare, whatever you want to call it. What are you doing? This isn't required. Now, could you do it? Yes, you can give this to someone saying, hey, Medicare doesn't ever consider this. But when you do it as a nicety, when you do it as that kind of informational purpose, then you're only going to complete the top part, which is item A, who you are, item B, who the patient is, item C, your system identification number, item D, you got to tell the patient what it is. Item E is Medicare does not cover this. Medicare coverage prohibits us from Medicare from paying this, something like that. So that would be E, and then F, a cost. One of the questions I was specifically asked about F is there a set standard for that cost? And with this, it's a little different. You're going to try to estimate as best you can what they would pay. I always tell people, start with what a private pay patient will pay and look at it from there. So if you were to bill this for a private pay patient, how much money would you charge them? Hopefully that helps you understand a little bit about cost. But from there on out, after you're done with F, you don't need to do the rest of this form. It is purely informational only, okay? Now, someone asks, okay, so if we're not doing the form, how is the patient, and if we're not doing the form or required to give the form, how is the patient informed? It's called the Medicare NU Guidebook. It is a CMS item that is sent to the patient. We're going to look at that, where to locate that in a little while when we get into resources, okay? One of the items that was questioned was there's a term called provisions of coverage or provisional coverage. And what does that mean? When you're reading through the Social Security Act, you'll see that it has to meet all provisions of coverage. What does that mean? Along with medical necessity. Well, that's just simply, hey, did you bill the primary first? Did you bill it timely? You have 1 year from the date of service or 1 year from the date of discharge or the through date on a institutional claim. Is there some underlying condition which could make it medically necessary? And this would be for foot care. So, is there a reason that it's not safe for them to do it on their own? Certain screening tests or exams and therapies is a provision of coverage that you have to have an approved prior authorization for this coverage, such as in a hospital outpatient department. Okay. Physical certification or an order. And is it an inpatient service? Now, I want to remind everyone that when we talk about these provisions of coverage in this whole section, we're talking about traditional fee-for-service Medicare. If you have a Medicare Advantage plan or a Part C plan and they say, no, that's not what we use, that is correct. They can use different things. What we can only address on this webinar is traditional fee-for-service Medicare. That's why the resources located starting in this section are all about traditional fee-for-service Medicare. But why don't we take a break so I can grab a drink of water and hear any questions that you've submitted in chat. So Karen, do we have anything in chat?
Yeah, Tom, we have gotten a couple questions. Back on slide 6, when you were going over services covered by a federal agency, you got a question that said, should the VA or TRICARE policies be billed first, then to Medicare?
Oh, good question. And this is a very interesting answer because really, especially with the VA, it's the patient's choice. Does the patient want to use their VA or Medicare coverage? Now, if they want to use their VA coverage and the VA comes back and says, nope, they didn't get a prior authorization, we're not making a payment, you can then bill Medicare, but Medicare will consider it primary. So we're not going to consider that the VA didn't do anything with it. It's just as if the patient didn't have VA coverage for that. TRICARE is different because TRICARE begins to kick in very differently. So first, yes, Medicare is primary for TRICARE for life people. It's one set of TRICARE. Otherwise, TRICARE can be primary. So it's a little different coverage. Now, if it's an active duty personnel, TRICARE is their primary insurance. So don't confuse VA and TRICARE. You follow the same guideline. One can pay for it, the other cannot. But in terms of billing, you kind of need to know which one they, one, want billed. So especially if it's VA, because that's a retiree plan. Two, if it's TRICARE for life, they're 65 and older with Medicare and TRICARE, then you're going to bill Medicare, then TRICARE. If they're active duty, you'll bill TRICARE, then Medicare. So there's lots of stuff going on in that situation. And that's like a separate realm of not covered services. Now, if it's truly a not covered services, Medicare won't pay for it anyway, so it shouldn't fit into that MSP category. Karen, any other questions with that? not necessarily with that, but any other questions?
Yeah, we did have one other question. Does traditional Medicare still instruct to perform a carve-out if the patient who is new to Medicare has scheduled a routine physical and a medically necessary chronic condition follow-up, and both were performed and supported in the documentation?
Absolutely. You have a non-covered service or a not covered service done with a service that Medicare will cover. So you need to determine which components go into the covered Medicare service, and you're required to bill that to Medicare. Everything else goes into the not covered service, and that gets billed directly to the patient. So when we talk about the chronic conditions and we talk about like maybe doing an evaluation of management or something else with it, what we really have to do is sit down and figure out the different components of it. It's the same thing if they come in and they're new, they're going to have their new to Medicare stuff done, and then they're going to have they're going to have a routine physical done. Well, okay, it can be two different things, and there may be more stuff done during the routine physical. You have to carve it out, carve them up separately. So hopefully that answers the question. If not, let's throw that back in. Otherwise, I'm going to go ahead and move on, and we'll take a few more questions at the end. All right. The first thing that people ask me, and I really thought was important to have links for you guys, is the laws and regulations, because the Social Security Act, which if you've never read it, you probably never want to, but it does have many different sections. And in particular, when you talk about Medicare, you're always looking at Section 1861. Now, I always say that, and then I shouldn't say always. What I should say is, for the most part, you're looking at Section 1861. There are a few other sections that do have provisions within it, and that's why they use the term under provisions of coverage or under the provisions of the law. I personally prefer just to simply use a search engine and put Social Security Act in there without having to go through all of it. If you do happen to have this PowerPoint, just select the link, which is literally the word Social Security Act. It's going to open it and it will bring up all of them. I don't really like this table of contents. Don't get me wrong. The reason I don't like it is I have to know where I'm going, which is Title 18. But once I get into Title 18, I still have to know all the different items that fall underneath this and what am I looking for within Title 18 in which section. What are my conditions? What are my limitations? And you're like, oh, okay. And then if you scroll all the way down, that's where you're getting into some of, you can see 1860 starts to appear. Here's your miscellaneous provisions, which cover everything. And this is where you get into some of those other items. Holy wow. So I'll tell you, it's a great place to read if you're looking for why someone has to do something. There's a lot of information on the law in there. I want to go back to the PowerPoint. I prefer just, knowing my sections, and that's why I've given you the references that I have. Again, I showed you how to find 1861. Now, the reason that I chose 1861 is it does provide definitions of services and institutions. So in other words, here's what you have to know. Here's when an inpatient is coverage. Here's an inpatient psych. What does that mean? And these definitions can then limit the coverage. Not the same as it's not medically necessary. It can mean, hey, you don't even meet the definition of a Medicare provider, all of those types of things. You can see I'm just kind of scrolling through. So there is quite a lot of information right here, though most people do find the Social Security Act very overwhelming, and we do understand that, okay? So let me move on to the next one, because this is the one that I like to tell people to take a look at. First, a lot of questions came in about WPS having a list on our website of not covered items, non-covered items, and we do not have one. We do not have one because we ask that you use the Medicare Benefit Policy Manual, Chapter 16, for general exclusions from coverage. And if you're looking for those providers that are excluded, we ask that you use the Medicare Program Integrity Manual, Chapter 10. This is where CMS actually lists the criteria of coverage. So it's really the list. Again, it's what you need to know. Let me show these to you too, because I think they can be a bit confusing if you're not familiar with where to go to look for these. So on cns.gov, start off going to the term Medicare. Once you're in Medicare, a lot of people think these should be in coverage. Now, coverage could bring you to an LCD or an NCD, which is the medical necessity section, which we already talked about. It's 1862A1A. But the reality is the regulations and guidance, and I want you to focus on the word guidance because that's what this is, your daily operating instructions or your guidance from CMS on how the Medicare program will run, is within manuals. So with that said, if you go to the center area and you look at the word manuals, you got 3 columns, and you're going to go to the middle one, the top item, manuals. When we go to the manuals, you'll see the Internet-Only Manuals right here at the top on the left. And then you get to scroll through and you get to read all these great things. Again, the Benefit Policy Manual, 100-02, Medicare Benefit Policy Manual. We're going to scroll down through these chapters. First, if you don't like a fast scroll, look away. I'll tell you when to look back. When I get towards the bottom, and you might want to look back now, you'll see chapter 16. This is where you'll actually see the word exclusions from coverage. If you open that, you can read through all the different stuff that they state in here, they being CMS and the daily operating instructions. Here's what we have to know about coverage. Here's that VA question. I'm just going to scroll down a little bit. You guys can see that there's, just to show you that there is a variety of different items within here. You can select any of these. It'll jump you to that section. You can take a look at any of them that you want. So if I wanted to go about cosmetic surgery, here's what I learned about cosmetic surgery. So this is your list. Okay, then I also said you need to go to the Program Integrity Manual. So I'm going to back select twice so that I come to the publications list. The Medicare Program Integrity Manual, which is 100-08, contains the provider enrollment information, which is in Chapter 10. Inside Chapter 10, you'll see the definition of each provider type and who can enroll, along with the facilities. This means that if you do not choose to enroll with Medicare or you're not eligible, this is that section for not covered services when someone is not eligible. You can look through any of the facility types. You can look through the businesses. You could also then look on down into the individuals, and that's how it's broken up. The last one is the suppliers. So if you want to know if there's a certain level of care that needs to be provided, if there's a certain criteria related to a licensure that needs to be provided, this is where you're going to go. So again, I think it's great. I think it's a really good resource. I'm going to go ahead and move on to slide 18, which you guys will see is listed as ABN resources. There's another manual listed here, so we'll go back to those lists of publication numbers. We're going to go to 100-04, Medicare Claims Processing Manual. A lot of people ask me about ABN and advice on that and where that comes from. It actually is in the financial liability protections area of the Medicare Claims Processing Manual, Chapter 30, Financial Liabilities Protection. So again, I'm going to ask you to look away if you don't like a fast scroll. Let me just quickly scroll down here. Here's the Financial Liability Protections area, and you can read through this, okay? If you're like, oh, I don't really know any of this, what's my written notice of evidence? I don't know what the ABN is, and I'm not really sure. Well, look at what Section 50 is all about. When to use it, when to not use it, all of that. So if we scroll down, oops, I meant 50.2, not 0.1, but that helps us. Here's when you have to give it. Okay. Here's when it's optional. And this is one of the things I wanted to point out with Section 1861. So it is referring to the Social Security Act and will tell you, okay, look up what you need here. So ABNs are not required. Let me answer that question again. ABNs are not required. They are given as a nicety if it is a never covered service, which is optional use. Okay. If it is a not medically necessary service as defined under one of these sections of the Social Security Act, then an ABN is required, but it's not part of today's information because I don't want to have to go through the full ABN use. ABNs are very complex in and of itself. I will tell you that a couple people did ask for some direction on the ABN when using it for not covered items. So to state that information, I do want you to go to Medicare. And again, I'm going to stay on the CMS website, but I'm going to go to a different section. We're going to go to Medicare. Now we can just kind of scroll around and be like, I don't really know what I need. I'm going to go to coverage. Beneficiary Notice Initiative is what we're looking for here. If I don't know where that is, I can always search it. Sorry, I just have to look through the different options here. I'm sorry, forms and notices. There's the Beneficiary Notice Initiative. I apologize for that. Once you're inside here, here's all the different headers and categories. But if you scroll down, you'll see on the bottom of the page, it'll actually tell you the ABN and the form instructions. So this is where you can get some additional information. Remember, a lot of these form instructions are provided for services that are not medically necessary because that's the required use. So hopefully that does help you. One item that I was specifically asked a couple of questions on is, again, the patient's information. So I wanted to show you how to find that in case you're ever wondering. The patient is informed about these non-covered or never covered services through Medicare and You, through a Medicare and You guidebook, handbook. So Medicare.gov, not CMS.gov, but Medicare.gov contains this information. Medicare.gov is the patient's website. You guys can take a look at it and use it whenever you want. So you want to know what CMS tells a patient? Look it up. Easy enough. Sometimes you actually want to give and say, hey, y'all got this sent to you. Did you even read it? I know sometimes that becomes problematic because the patients don't necessarily understand. How many of you have had to try to explain to a patient when something's covered and why it's not covered? And this answer simply is, well, CMS said no, or Medicare said no, or the federal government said no. This is a resource that will help you with that. Okay. So go to the basics. Sorry, let me get that off of there. Go to the basics and go to Medicare and You handbook right here. For those of you that are not familiar with the handbook, you can choose to download it. You can look at it. Now, the reason that this is important is this is the Medicare coverage guideline sent to the patient annually with updates. So every year they get a new one. Some patients will say, well, I don't get that, because each household may get it. So let's say that you have a mother and a father and a child all on Medicare. Parents due to age, child due to disability, all three of them can get one copy per the household. That's an option that they do have the right to choose from. Okay. If we want to download it, we want to take a quick look at it, we can click the download button, again, lower right corner, and you can look through the total information given to this patient, all 128 pages. So it's a fast, easy way for them to access different pieces of information. You can look up whatever you want to look up here. But I thought that that was an interesting question, because if you're trying to look for something and you're trying to help the patient to understand, this is a great resource because it's written at an 8th grade or below level, many times about 6th grade, really to help the patient grasp what they need. But I want to remind you, if even after giving them this or trying to explain it, it's not your responsibility to get the patient to understand their benefits. It is their responsibility to understand their benefits, which means you should refer them to 1-800-MEDICARE for more information. So again, lots going on there. I did kind of skip through some of these different slides. Somebody asked me for the phone number for 1-800-MEDICARE. It is 1-800-633-4227. That's what Medicare translates to. Which brings us back to that fun-filled section, and this is the question and answer area. Now, I will tell you what I've done is gone through those pre-submitted questions. I'd like to get through the slides and the questions that are built in, then we will move on to the chat questions. Now, I've done a couple of chat questions already, so we will get back to those. First, and again, I put this in here because isn't ABN required? No, CMS does define this as an optional use. Please check out the Medicare Claims Processing Manual, Chapter 30 for further information. Information on this is on slide 13 and 18. Just kind of highlight, make a note. Maybe you want to do that. I don't know. Next is why does CMS tell the, or why does Medicare tell the patient the claim is billed wrong? First, we can't actually answer this. That's 1-800-Medicare telling that to the patient, not us. We don't know why they do what they do. Now, because this is a separate contractor, you have to also remember the patient is what gives them the information. We have no idea what the patient is saying to 1-800-Medicare. If you've ever heard some of those pieces of information that they give, they may not be giving all the information. They may be giving wrong information. So they're saying that based on what they're getting from the patient. However, their technical answer should be, if you don't agree with the decision, you should be filing an appeal to have Medicare look at it again. So when they say it's billed wrong, that's not something that may be true. You may have billed it absolutely correct. You do need to refer this back to CMS regional office. They're the ones that actually will have to take it up, or you can refer to central office for the 1-800-Medicare giving wrong information. The hardest part, though, is that they then have to review the call to determine whether it's actually wrong information or whether they just didn't get a valid question from the patient that was able to give them any different information. Are the criteria the same for Medicare Advantage plans as traditional Medicare? I cannot speak for an individual plan. Each individual plan has their own rules, criteria, and the way things must process. Here's what we can say. They are separate from traditional fee-for-service Medicare. Again, each plan is separate. They must offer the same items for payments, but they can pay them differently. They can include them in different items. There are a variety of other factors that can come into play. MA plans may also choose to offer additional coverage. That's why you got to contact each one individually to figure out how they want it billed, what they want within it. We do not have access to their systems. Does Medicare cover vaccines for people traveling overseas? The answer to this one is to the extent that they're covered under the benefit package. So if they're covered because it's the season and so you're getting a COVID shot or you're getting a flu shot, you're getting a pneumonia shot, sure, we would cover that. If you're getting a tetanus shot in advance that you might go over and get tetanus somewhere, but we're like, wait, you had one. Okay, nope, that might not be covered. And so can you tell me when you're getting it? Is it within the normal timeframes? Is it within the coverage criteria and the guidelines as set up for that vaccine? It could be covered. But just because you're going overseas and you need a vaccine, that's considered routine and is not covered. Does Medicare show this as a billing problem? Now, this one was interesting, and I'm not really sure where they were going with this one because that is the question that we got. So let me just give you an answer. The data does support that these services are frequently billed. It may be a variety of reasons. Some of those may be a problematic reason. Some of those may not be a problematic reason, such as the patient wants it billed, or the patient has a secondary insurance and you need the denial for secondary insurance. However, what we've done is just looked at it and said, it's a lot of denials for a non-covered service for a 3-month period, June, July, and August of 2025. And I listed the actual numbers, but again, we aren't really sure whether this is all problematic or not, okay? I'm gonna answer a few more pre-submitted questions, then we will take anything done in the chat. When to bill the patient with secondary coverage if you should be giving an ABN. Okay, well, the secondary guidelines don't mean that you don't follow Medicare coverage. It does mean that if you are required to give an ABN for the Medicare guidelines, then you are required to give an ABN regardless of primary coverage. Regardless of primary coverage, you're still following that. If it's a never covered or not covered service, you don't have to give one. You still don't have to give one. You can, you just don't need to. Okay. We talked about this real briefly, but how to search WPS for a non-covered service. We do not have a list of non-covered services on WPS. It just doesn't exist. There's a question coming in about modifiers, and it's the ND to DN, which are ambulance modifiers. And why are these being denied when they should be covered? We don't know that from a claims data section. I would need to look at your claim a bit more. Will these appear that they should be covered? Part of the denial would also be skilled nursing facility consolidated billing, which has nothing to do with not or never covered. It's a bundling coverage issue, which means that it should be billed back to the skilled nursing facility. So I don't know exactly what's happening here. If you have specific questions, take your ICN and contact customer service. Next question is not about non-covered, but it says, does the GZ modifier change claims processing in any way? And the answer is no, it doesn't change anything. GZ simply means I didn't bill, I didn't give an ABM when I needed to for a not medically necessary service. It has nothing to do with a not covered service. Okay. We already answered this one, but does Medicare do the carve out? Yes, yes it does. Is anything different for a rural health clinic? Nope, rural health clinics are still subject to all the not covered criteria. They're still billed to Medicare. What types of supplies, or I'm sorry, more information on billing supplies. I don't really know what you're looking for. So help me understand who that goes with. What are you looking for there? With that said, I would like to open it up to chat questions briefly, and we'll take a couple of those and then we'll get going again. So Karen, anything in chat that I haven't answered?
Tom, we did have one more question come in. If the patient has Part A and a secondary private, is it required to bill the Medicare A for the denial in order for the secondary to pay?
That is something that if the secondary is asking for it, you should bill it. Now remember, with Part A, if it's an inpatient, you might need to bill it even though it doesn't meet the technical criteria. So you might need to bill a no pay claim just to continue the benefit period. I'm not really sure what's going on and why while you're doing that. So if we require a no pay claim to be billed, yes. So we want to make sure you're following those criteria. If it is truly just not billed and the secondary saying, look, we're not paying it without that denial, please feel free. Please feel free to bill that. Okay. Next question, if we have one.
We do have one. It looks like Jennifer did clarify and say it was for ambulance billing.
Okay.
So,
I'm not sure what the questions is referring to. So Jennifer, can you give me
one
a little bit more?
that was the one we were just talking about. The Medicare patient has Part A and a secondary private, so this would be for ambulance billing. Is it required to bill Medicare A for the denial?
Again, it's going to depend on what that secondary wants. If they're requiring you to bill it so that you can get that, then yeah, go ahead and bill it. Please remember that on an ambulance claim, it is a bit different. And yes, you do need to append either the G Y or the GX, just indicating whether or not you gave an ABN. Now that's because ambulance claims don't require diagnoses for payment. They may be required for claim submission, but they're not for payment. So you do have to indicate whether or not they meet section 1861S7, which is where counterindicated, or the service has to be medically necessary for us even to consider it. That's why if it's not, you will need to include the GY or the GX. So hopefully that answers your question. If not, let me know. In terms of Medicare, no, we don't require you to bill it. But if the primary needs it for that billing, then yes, you would want to bill it for that purpose. So hopefully that answers the question. Again, if not, let me know. Otherwise, Karen, any other questions?
Last question was, can you please repeat the information provided regarding the GZ modifier?
Oh, sure. GZ modifier means that you should have given an ABN for a medical necessity denial. It is not related to not covered services. Again, GY, GX, not covered. GA, GZ, not medically necessary. So when you're looking at GZ, it does not affect our claims processing system in any way. It is purely informational. GY and GX do affect the claims processing system. I'm not sure what else I could be missing on that. So if you need more, put it in there. Karen and I will actually send you more information. At this point, I'm going to go ahead and go on though. All right. Karen's going to put a link into the chat for you. It's about our survey, and we just ask that you take this survey. Help us understand that we get you what you needed. Again, we really focus on what you sent in, the questions that you asked, a lot of different information given from that point of view. So I'm hoping I did. But please provide us any feedback that you have, and the survey will give that to you. All right. So we really do encourage you to take that. A couple of things to keep in mind. There's a link right now in the chat. We will also give you the opportunity to click on a continue button. Looks like this one right here. It is us asking you. This isn't spam. This isn't malicious software. This isn't anything like that. We're asking you to go to our survey. Last, you'll be given the opportunity to take it online. Should you be listening to this as an encore, that's done through the online survey button. Okay. I want to remind everyone that it is the end of the year because it's the end of a calendar year. What does that mean? That means that if you bill under the Medicare physician fee schedule, you can look at your participation status with Medicare, which means yes or no, do you accept assignment on all claims? And if you want to change that, you can. If you don't want to make any action, don't do anything, you're good. But let's say that you are non-participating and you do want to move to participation, you're welcome to do that. If you want to learn more about this, print the PowerPoint, read the notes, or go to the CMS webpage right here. This will help you get through that. Remember, the participation status is something that you must do through the provider enrollment process. All right, that brings us to the end. Just a couple of things. In a few more moments, we're going to get an email saying thank you. Don't delete it. It does contain your certificate of achievement with contact hours. Contact hours are used by governing bodies to issue CEUs. We don't actually issue CEUs. We do issue contact hours. So make sure you open that up and read through that. It'll also give you the opportunity to take that information as well on the survey. If you have additional questions, you have 7 days to send those to us. Karen put the email, and then just make sure in the subject line you put not covered services webinar. We simply do that to make sure that it comes to me and Karen so we can get it directed back to you. Ways that we'll do that is we'll respond to everyone. We'll respond to you individually. It just depends on the question. So thank you for listening today. I do appreciate any feedback on this survey. On behalf of myself and Karen, all of Provider Outreach and Education, you may now disconnect. Thanks for your time and effort today.